Welcome, everybody, to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic, ocular pharmacology, utilizing old and new medications in eye care. And our speaker is Dr. Greg Caldwell, a graduate of the Pennsylvania College of Optometry. He also completed a one-year residency in primary care and ocular disease at the Eye Institute in Philadelphia. He is a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, and a member of the Optometric Glaucoma Society, and a member of the Optometric Wellness and Nutrition Society. Currently works in Duncansville, PA as an ocular disease consultant. His primary focus is the diagnosis and management of anterior and posterior segment ocular disease, and has participated in multiple FDA clinical trials and investigations. He has integrated nutrition, prevention, and wellness into his patient care. He practices integrative optometry as such. He is a co-founder of Optometric Education Consultants and co-administrator of a nice resource on Facebook, OCT Connect on Facebook. He's lectured extensively throughout the country in over 13 countries internationally. In 2010, he served as the president of the Pennsylvania Optometric Association and was on the AOA Board of Trustees from 2013 through 2016. He is president of the Blair Clearfield Association for the Blind. And in 2023, he was named by Newsweek magazine as one of the top eye doctors in the United States. So with that, please give a nice warm virtual welcome to my partner, Dr. Greg Caldwell.
Thanks, Joe, and thanks for that nice introduction there. And again, we are going to be talking ocular pharmacology, some old, some new. And today we had a medication approved. So disclosures, as this is a COPE approved, the content was prepared independently by me. As you hear me say a lot of times, I put these lists up here: Allergan to Hero, Tarsus to Allergan, advisory boards, not really to show off, but in order to stay connected and give you the most updated information. Really nothing tonight I'm going to talk too much about is tied into any of this. I do sit as the PA medical director for Involve, healthcare registries for chairman for diabetes and AMD. But probably that last bullet point, second to last there, the content and the format is presented without commercial bias and does not claim superiority over any commercial products or service. And the final comment will be all of this these relationships have been mitigated through COPE. All right. So the first thing I'm going to talk about tonight is mechanism of action versus mechanism of delivery. So the mechanism of action is, like steroids and how they suppress the immune system, or, prostaglandin analog is how it remodels the uveoscleral meshwork, so on and so forth. And when new medications come out, is it a new mechanism of action or is it a new mechanism of delivery, right? We're going to talk about that, like when the loteprednals, all these new loteprednals came out, but some went to nanotechnology so they can slip through that mucous membrane, right? And that's that mucous membrane penetrating. When Vuity came out, right, it was, is that just another pilocarpine? No, we're going to talk about it a little bit tonight. They changed the pH, they changed the mechanism of delivery that's out there. So sometimes it's both. Sometimes it's a mild change to the mechanism of action. Like when Cequa came out, it's still cyclosporin. Yeah, they bumped up the percentage, but the mechanism of action is that's not going to change cyclosporin. But when they wrapped it in that, that micellar type of molecule, they were trying, because cyclosporin is a fat loving, it doesn't really mix well with the tears. They were trying to get it as a water loving, and then it kind of releases and delivers the medication. So you're going to hear me talk about mechanism of action at times, mechanism of delivery when it comes to certain, medications. I just wanted to clear that up. And I would encourage you, whenever something new comes out or your reps come in, to try and figure out, are they trying to talk about mechanism of action or mechanism of delivery? So here, like this here, it says amplify. This is whenever, the Kalo, which is now Alcon, came out, and they had nano particulars. They shrunk it down to 500 microns, and then they made it so that it can penetrate, and they made it slimy, and so on and so forth. So really the loteprednol, changing that carbon 20 that really was still the same thing to make it, from a ketone to an ester. Nothing really changed in the mechanism of action. So that was really more of a mechanism of delivery. So with that said, we're going to do we're going to hit some antibiotics here. So let me just launch this polling question here. A patient comes in, they have a dacryocystitis, right? They're allergic to penicillin and Keflex, like a really bad allergy to, where they carry an EpiPen. Which antibiotic would you use? And I have this set up as a multiple choice. There could be a couple different answers here, but which antibiotic would you use to treat this kind of nasty mucopurulent type of infection going on here? This is definitely bacterial infection. Which antibiotic would we use here? They're allergic to penicillin. They're allergic to Keflex, Augmentin, azithromycin, cephalexin, Bactrim, or Cipro. And it looks like we got a good enough reply here. It takes about a minute. So I'm going to end the poll. I'm going to share it. And we're going to revisit this after we come back. So I'm not going to really make too many comments. I got the same polling question, I think is number 3. Let's see, maybe I should found the percentages here. We got 9%, we've got 44%, 5, 30, and 22. All right. So I'm going to stop sharing and we're going to jump in here. So this was my antibiotic paradigm through 2019. I know people like to screenshot and do certain things. Wait to the next or take a picture. Wait to the next slide. So you're going to see here I have Augmentin and Zithromax, Keflex, Cipro, and Bactrim. And what had happened over the course of time as more Cipro was being used and more side effects, it's still Augmentin and Zithromax as my go-to, Keflex. But then what happened in 2020, Bactrim as the sulfa drug moved up to what I call the 4th position of things for me to think of. And the quinolones, because of all the adverse effects, dropped down to that 5th position. So, someone comes in and they have a penicillin allergy, I'm going to avoid Augmentin. My next go-to is going to be the macrolide, which would be, in this case, would be Zithromax. So let's see here. Where am I? Right there. So polling question number 2 is, have you ever had a patient allergic to a sulfa antibiotic and you prescribed Trusop, Azop, Cosop, Diamox, and hey, wait, there wasn't a reaction? So yes, no, or I would never do that. Patient has a sulfa antibiotic reaction, allergy.
And I just relaunched the handouts, same material, 2 different forms.
So have you ever had that happen? You're treating glaucoma. Geez, I have a sulfur allergy. I'm going to try Azop. I'm going to try Trusop. All right. Looks like we got a pretty good amount of people rolling in here. Looks like a few more coming in. I'm going to end the poll, share the results. And I see 28% have had that happen in a positive way, I guess. 56%. And then we have 16 saying I wouldn't do that. Let me try to unravel this in a few slides here, or a slide, this sulfa allergy that's out there. So in cross reactions. So if you have a penicillin reaction, you have to be careful with the 1st generation cephalosporins. And that's because the molecules look pretty similar that's out there. The drug of choice, whenever someone has a penicillin allergy, or the category of choice, would be your macrolides. So if someone has a penicillin allergy, then I just go right to Zithromax. If they have a penicillin allergy and it's severe, I'd probably avoid cephalosporins, because there is that 10% in the 1st generation As you get to the second, third, fourth, I think there's 7 generations now of cephalosporin. Second, third, the molecule, the organic structure changes enough that the allergic reaction, that immunoglobulin reaction, that hypersensitivity, the molecule has changed enough that you don't have to be concerned in that second or third. So that's why we just say the first generation. Then we would move to sulfa. And then what happens if they have a sulfa allergy, and then quinolines? Well, I've heard people say before, like, if you're allergic to sulfa, you're going to be allergic to kind of this whole group that's out there. So that's not true. I'm going to try to unravel that right here. When someone has a sulfa antibiotic allergy, right? True allergy, mast cells, IgE, immunoglobulin E mediated, hives, itching, congestion, lip, that's that anaphylaxis. They're not allergic to the S in this molecule, right? They're not allergic to the sulfa. This thing right here, you can see it's listed. It says aryl amine group. That's this thing right here. This is the hapten. This is what the person is allergic to. So it's not really the sulfa when they have a sulfa allergy to an antibiotic. It's this aryl amine group. So this is what the patient is allergic to. So all the sulfa antibiotics have this aryl amine group, which is the hapten or the antigen that this IgE is reacting to. It's not the sulfa. So that's why when you look at a sulfonamide antibiotic, they have this aryl amine group. The S is right here. And so you're going to have the IgE reaction. So if someone has a sulfa antibiotic, you're not going to really give any of the sulfonamides because they all have the aryl amine group. So you don't prescribe them. When you jump over to here, diamoxin, neптazane, and Trusop, for that group it's still there, that 28% that said, hey, yes, they've done it and they've had that happen. If you notice, it doesn't have this N aryl amine group. It's totally different. It's the sulfa drug. It's a sulfonamide, but it doesn't have the hapten, and that's why you're able to give this medication that's out there. And then if you jump over here to the sulfates and the sulfites, it is so, again, it has a sulfa, but they're not allergic to the sulfa. They're allergic to this aryl amine group. And that's why things like atropine and gentamicin and timolol, which are sulfates and sulfites and sulfur medications, there's really no concern that's out there. So what you're looking for is the patient to be allergic to the antibiotic. If they're allergic to the antibiotic, as you can see here, you can prescribe these with caution, see what happens. And the sulfate, the sulfites, and the sulfurs, you don't really have any problems. Now, if someone is allergic to Trusop and Azop, then there's something in this molecule that they're allergic to. So pretty much if they're in these categories, you're going to want to pretty much avoid them. But a sulfa antibiotic, to sum it all up, avoid the antibiotics. The other sulfonamide and sulfate, sulfur, and sulfite you can prescribe. And that's why 28% have had this pretty much the same thing that I have witnessed over the times when people come in and they have a Bactrim type of antibiotic reaction, but they have glaucoma. I can still prescribe that COSOP and not have a problem. So, all right. So it's that bad boy there. So let's go through the antibiotics here real quick. So amoxicillin and clavulanic acid, that's Augmentin, right? It's the uber amoxicillin. I'll have people come up and say, I'm not sure about this amoxicillin thing, doc, because I've used it in the past and had failures. Well, the key here, if you remember, bacteria produces beta-lactamase. That's that ring that it's like the defense mechanism that it's in that pus that cleaves the amoxicillin, makes it inactive. That's the clavulanic acid, is that when both come in and the beta lactamase looks at, oh, amoxicillin or the clavulanic acid, it's more attracted. It has that higher affinity for the beta lactamase, the clavulanic acid. So lack of a better term, it absorbs it, makes it inactive, and allows the amoxicillin to work. So that's why it's an uber, amoxicillin, if you want to say that, because it works really well. So that's usually my go-to, as long as they don't have a penicillin allergy. And really the reason is you can use it up to 12 weeks of age. You could use it in pediatrics, adult, geriatrics. It's safe in pregnancy. It's a category B. The only thing you have to really remember is look for that penicillin allergy. And really the dosing is 500/125. The 125 is the clavulanic acid. And you usually do it twice a day by mouth. And I'll do anywhere from 7 to 10 days, right? It's when people come in with a dacryocystitis, like I was showing earlier, or a sty. I like to maybe do 10 days because it's hard with the blood-brain barrier to get medication there. So anywhere from 7 to 10 days, 500. If you have someone that comes in that's, linebacker for the Pittsburgh Steelers, you might do 875/125. And if you have someone that's maybe petite and you think you might beat them up, but you're not going to get that therapeutic. So when I lecture with Dr. Offerdahl, the pharmacist, usually the two are either 500 or 875 of the Augmentin. It covers everything. So it's really good for gram-positive, gram-negatives. So the gram-positive here would be your staph and strep, and your Haemophilus influenza would be your negative. So it's a nice broad spectrum antibiotic. Really, the only thing you have to really worry about is, are they allergic to penicillin? Again, pregnancies, pediatrics, adult, geriatrics, very safe medication. And then we're going to jump into the azithromycin as we go down through that category that I showed you. It's macrolide. It's a prototype of a erythromycin. It's a drug of choice for penicillin-sensitive patients. All age groups, again, so pediatrics all the way up to geriatrics. And again, really safe. The only thing I have to really see if they're allergic to the macrolides type of antibiotic that would be out there. So the big one that we'd look for would be, if they've ever taken erythromycin. The nice thing about it, there's no renal adjustment. And basically, I think we're all familiar with the 5-day Z-Pack and the 3-day tri-pack, right? There's Z-Packs 5 days, 3 days. It's the same amount of medication. It's $250 on the first day, and then $250, $250, $250 day 2 through 5. And then it's still the same 6 pills here. And here's the children dosage if you need it for reference. A lot of times I just call the pediatrician up and work with the pediatrician, and then, work with the pharmacist. Again, it's great for gram-positive, gram-negative, and it's better tolerated than erythromycin. And that's why erythromycin is very rarely used, because of the GI upset. It is the drug of choice for chlamydia, 1 gram. So basically 4 pills, chlamydia, infections of the eye. So again, it's my little cute way to remember, like if you want everything to stay in Vegas, that happens in Vegas, you basically can take your 4 pills of azithromycin with you, or azithromycin or zithromax with you. And it used to be the McCarran Airport. And last time I was out there, I plugged it into the Uber, and I was like, oh my gosh, where's the airport? It's a different name now. It's something Brown or something. So I used to say before heading off to the airport, grab a bottle of water, but just a cute way to try to remember that's the drug of choice for chlamydia conjunctivitis. So Keflex, first generation, there's a cross reaction anywhere from, depending on what literature you read, anywhere from as low as 3% to 10% cross reaction. So this patient that I was talking about that had the dacryocystitis, they had an EpiPen type of reaction. I probably wouldn't push the luck. Maybe if they had some other kind of adverse event that wasn't as serious as anaphylaxis, maybe I would consider Keflex if they had a penicillin. But we have Bactrim, we have Cipro, we've got azithromycin, we have other things to consider that we don't have to really put the patient at harm. It's the first generation. It's, moderately effective against that penicillinase, that beta lactamase. A little bit better for the gram positives that's out there. Oop, I got my old mouse here, so things are going to be a little sloppy here tonight. But it's available 250 and 500. Typically, it's 500 milligrams twice a day for a week, and it's a category B. So pretty much everything we've covered to this point, whether it is Augmentin or azithromycin or the Keflex, it's really safe if the patient comes in and they're pregnant. And it's a drug of choice for blowout fractures. And it's, you see a lot of times that's what will happen. Someone goes to the ER, they usually see them come in on Keflex because that's still kind of the rule of thumb in the ERs. When you jump into, Sefton, which is the second generation, we start using this a little bit more in the pediatric population, because it's that pediatrics can usually get more of a gram negative, unless you're doing PCR testing, you're not really sure, but rule of thumb, adults get gram positive, children get gram negative. That's out there. So that's why you try and go a little bit more specific. And here's the pediatric dosing that's available. And it's a category B. And really, here's the cross reaction. I don't really expect people to really memorize or remember what these organic structures are, but basically this one is penicillin. And you could see that, we have this box and this N and this H, and here's this same box and N and H. So when your body makes that, it goes back to the immune system. You're going to see me talk about that a little bit more as we get into some of the biologics. But when your body goes to the T cells and the B cells and the plasma, and then it makes the antibody that's going to attack and create that hypersensitivity to this molecule for that immunoglobulin type of hypersensitivity. These two look similar. So that's why there's that 3 to 10% cross reaction. But you can see that when you get down to the second generation, that molecule changes enough that it kind of fools that IgE molecule and that hypersensitivity to not have that allergic reaction. So that's why it's really just the first generation cephalosporins, but it comes down to the organic structures of why that happens. So Sulfa Drugs, I have it listed here. Single strength, you got 480. I talked to Tracy again. She's the pharmacist that I lecture with quite a bit. And she talks about, that's hardly ever prescribed. It's usually Bactrim double strength, where you have 800 milligrams of the sulfa agent and you have 160 milligrams of the trimethoprim. So it's usually DS, which stands for double strength, which is what's used in an infection. And it just happened last week or 2 weeks ago that a patient came in and it was, I'm allergic to penicillin. What happens? I get hives. What happens when I take a macrolide? They get really sick. Okay, we're going to avoid Keflex. Boom, now I hit my sulfa medication. And it cleared the infection up really, really nice. That was there. If they would have been allergic to the sulfa medication, then I would have then jumped to Cipro. And now this really comes to be the true kind of, in a sense, in my opinion, the end of the line antibiotic. They're really effective. They're broad. They cover gram positive, they cover gram negative. It's if they're allergic to everything, as we just went through. But now there's some things you have to remember. In the oral form, you really only want to give it to patients that are 18 years or older. And the reason why I say that is because there are Cipro drops, there's ofloxacin drops. The topical medications doesn't play by that rule. It's the oral medications that are 18 years older. I got to remember that. There's basically, if you're going to prescribe it, it's 500 milligrams twice a day for a week for Cipro. And it's, again, 500, that's twice a day. And then it's once a day for Levaquin that's out there. But if you stay up late at night and you're watching, have you ever take Levaquin and had tendon ruptures? And the tendon ruptures can just happen by it taking just one time, for a week. And the tendon rupture can happen at that time, or it can be reported like a year later. So it basically is some type of immunological reaction to the collagen and the elastin in the tendons and how it attaches to the bone. And you can have these tendon ruptures that are out there. So there's been other types of adverse events that have occurred. And that's why, we've kind of moved the fluoroquinolones or the quinolones down orally to the kind of that fifth position because of all the different types of adverse events that's out there. And I think there's a QT or QR, one of the heart type of issues that are out there. So again, it used to be the fourth position. I've slid it down just because of the adverse events. So let's see how we did here. We have this patient that comes in and they have a severe reaction to penicillin and Keflex. Which antibiotic would you use? Would it be augmentin, azithromycin, cephalexin, Bactrim, or Cipro? And I have it set up as multiple choice because there's a couple answers in there that I would think that are acceptable. Joe, any comments on antibiotics? Anything that you're using in your practice or anything?
The only thing that is, I wasn't sure if you were going to touch on it. This is just kind of a new use of an old drug. They looked at meibomian gland disease, and they compared using 6 weeks of doxycycline versus 3 doses of azithromycin. They found that 3 doses of azithromycin was as effective in dealing with rosacea and meibomian gland disease as 6 weeks of twice-a-day doxycycline. So that's what I generally have gravitated for. It's 6 pills, 500 milligrams azithromycin, 2 pills once a week for 3 weeks.
Well, there you go. Yeah, sometimes I do kind of talk about doxy, minnow, and then we'll fold in the azithromycin in my full kind of antibiotic lecture. I'm glad you brought it up because I'm not going to cover that tonight. And they would be using that kind of more for its anti-inflammatory part of that rather than the for the anti-infective side.
So, and a lot of people have a sensitivity or the tummy gets upset with doxy, and they get to take 2 pills for 6 weeks every day. This is 6 pills done 3 times, easy.
Perfect. Yep. Thank you. And check that out, right? So before we had 9%, we dropped that down to 2. Obviously, we want to avoid, as it's showing there, augmentin and cephalexin. That's your Keflex. I would agree. Your go-to for the safety part would be azithromycin. But I agree, Bactrim and Cipro, and that's kind of neat how education works, right? So it just kind of shows that that it's out there, and that's why we can do this synchronous live type of education. So, all right, let's jump into some oral herpetic disease here. When we think about oral herpetic eye disease, so we have this, herpes simplex over here, zoster, 2 different types of organisms here. We kind of think of Valtrex, acyclovir, and Famvir. When I do my full herpetic lecture, we talked a little bit about Neurontin and Lyrica, and Joe was talking about doxycycline and azithromycin replacing it. We're kind of more using it for its anti-inflammatory. There's L-lysine and Tagamet and the tricyclic antidepressants. For this next kind of few minutes, what I kind of want to focus on is just the Valtrex and the kind of the anti-infective side rather than maybe more some of this anti-inflammatory post-herpetic neuralgia type of. So some fun facts about herpes. I'm not sure with COVID where that all fell and where it is now, but take COVID out of the equation, the herpes viruses are the leading cause of human viral disease. It's only second. That's why I say that the influenza and cold sore viruses, let's just kind of delete COVID out of this equation. And then this came about whenever I was doing a lecture one time and someone in the audience raised their hand and said, hey, my dog has herpes. Can I contract it? I'm like, hey, I have no idea. And got to get some veterinarians in here now as a kind of our interprofessional type of education. And so I looked it up, and in doing that, maybe that number's higher, but at the last time I looked, it was 130 herpes viruses have been identified. But of those 130 or maybe plus now, 8 of them infect humans. And of those 8, 5 of them can infect the eye. And that's your herpes simplex 1, 2, the varicella zoster virus, or zoster, then you have Epstein-Barr in your cytomegalo. So pretty much everyone on here is probably in patient care. So if you would go test your blood for the herpes antibodies, probably all of us would test positive at some point, in patient care or in our life. We became sick and it was the herpes 1, 2, or the zoster virus that was there. So we probably would all test positive for that type of antibody. So sometimes they get labeled as human herpes virus 1, 2. You can see that there's 9. Sometimes they split 6 and 7 here, so on and so forth. And you can see it's the simplex 1 and 2, zoster, Epstein-Barr. But these are the 5 right here that can affect the eye. And what you need to know is really this, is the latency. Where do these viruses hang out, right? These viruses, in a sense, they're in my body, right? I probably have herpes zoster in my neurons. I probably have herpes simplex in my neurons. And the reason why I say that is that's where they hang out. That's why they come in this, I'm going to go way back. That's why they come out in this kind of pattern, right? This is the trigeminal nerve. They kind of hang out in the neurons. The trigeminal nerve hangs out in the nerve. And as your immune system can't keep that virus from replicating and it expands, it decides to come out. And in this case, on the cornea, this is herpes simplex. And in this case, because it's a neuronal virus, it comes out in this pattern of the trigeminal nerve as the zoster virus. So it's really because of where it lives as a neuronal virus. And that's why Epstein-Barr or cytomegalovirus, they believe it kind of hangs out. Look where it hangs out. The monocytes, the lymphocytes, those are the ones that are part of our immune system. So it's kind of the Trojan horse type of approach here. When you get down to these other ones, you can see T lymphocytes, again, part of that kind of that adaptive immune system. So that's just kind of where they hang out. But this is right here, these 3 right here is why you get those kind of classic patterns. Herpes simplex virus is the leading cause of cornea vision loss in the United States. I didn't say third world country, second, whatever. In the United States, if we say what is the leading cause of cornea vision loss, it is herpes simplex. And then we have this nomenclature where it's infectious when it's the epithelium and stroma. And then you have your endothelialitis, and then you have neurotrophic keratopathy. And again, it's a neuronal virus. And if you this is just a real quick review of the ophthalmic division, the maxillary division, and the mandibular division. And you could see here, if the tip of the nose is involved, you have a good chance that the globe is going to be involved because it's coming down that kind of that nasociliary, so the eye could be involved. When that nose is not involved, in a sense, you can see here, the nose is not involved. He's got the lesions of his forehead, that ophthalmic division, but the eye is really not involved. And the same thing here. I thought this was really, really cool. She came in, we caught this super early. She kind of had this kind of red eye, swelling, kind of crawling feeling on her forehead. But it wasn't until I pushed the slit lamp away and kind of looked around and pushed her hair back that if you look right here, look how that kind of looks like a dendrite. And that's what actually, when I took that picture and looked at it, I said, oh, I know what you got. You've got the zoster coming out, right? It's coming through that trigeminal nerve. You can see kind of the blister here. You can start to see the eruptions here. And we were able to get her on, her Valtrex and calm her down pretty quickly. And
hey,
you
Greg,
can see, yes.
Greg, she didn't have the dreaded spider bite.
Yeah, how about that? It's funny. We just had a talk about that the other day. A lady came in. I had the old spider bite, Stye, Chalazion, zoster.
Yeah.
It's kind of funny how that's kind of universal, Joe.
I've come to appreciate that since listening to you talk about it. When a patient comes in with the dreaded spider bite, I tell my techs and it's never a spider bite. It's zoster. It's shingles.
That's right. Exactly. The dreaded spider bite. And again, these are just to kind of remind you, this is some late stage. You can see here what's happened to this gentleman, but it's again, that's that neuronal part is what I want to point out. All right, so it looks like we got a polling question here that we need to launch. So the polling question is, have you ever wondered why a primary care physician sends you a zoster patient? So I just had one the other day, came in, patient, and it was actually, Joe, I think I sent you the videos. It was a Bell's palsy patient.
Yep.
Yeah.
And coincidentally, I had the same situation today already.
So, why do they do that? Why does these primary care people, with these zoster infections, they put them on oral Valtrex, they put them on prednisone, and then they send them to you? Like, what the heck, they already treated them. What's going on here? All right. So yes says it happened. No, it's never happened to me. And I think we got a pretty good response here. So we're just going to share the results. It's kind of mixed, it's 31, 39, and 40% here. So this is why right here, I work really closely. You'll hear Joe and I, we advocate all the time being a part of the team. If there's anything that, not sure, when I went to school back in 1991, 95, we were optometry, we were fighting for therapeutics. We worked a little bit with the specialties, but man, do I, constantly talking to the PCPs and helping them out and with MRIs, MRAs, or whatever we're ordering, blood work, and so on and so forth. So I was just chatting to the primary care doc, like, okay, why are you sending this to me? And the reason being is when they go to school and they learn about zoster, they realize that, when they go to school, that episcleritis, scleritis, keratitis, uveitis, iris atrophy, glaucoma, vitritis, retinitis, choroiditis, optic neuritis, and cranial nerve palsies can occur. So when they come in and they've been diagnosed and they've properly been treated, what they want is a good exam. And here's a classic case. As you can see, the tip of the nose is involved and the eye is involved here, the globe. But they could still come in like this gentleman here. They're still going to send you over. What they want to make sure is that the front of the eye, and they're not really good at looking in the back of the eye, making sure that there's no vitritis, retinitis, choroiditis going on, and they just want a nice little letter back. So, I get those all the time. They're nice little consults. They're already been prescribed. They're already in the medications. They're just making sure that there's no anterior or posterior segment disease going on.
And Greg, when we get the letter back, what does that letter always, when we send the letter back, what does that letter always say? I very much enjoy sharing the care of your patient. Thank you very much.
Yep, exactly. Yep.
Good point. Interesting, Greg, if you pop back a little bit to a couple of those images, not so much that, that one would be fine. What I find that the primary care physicians and the patients especially, if there's a lesion that's getting kind of on the temporal, getting kind of close to the eye, they get very worried that somehow it's going to spread into the eye. They don't really have especially the patients, they don't have that knowledge that it isn't something that's going to go, creeping across your face. It's neuronal and it's coming from your ganglia. They don't really quite understand the tip of the nose. And I have to explain to them, it isn't the fact that you have a lesion that's kind of close to your eyelid. It's a lesion on your nose that we have to worry about.
Yep, exactly.
But they seem to think that if it's close, it's gonna spread into the eye. And I tell them, by the time I see you in this situation, you got it or you don't. At that point, it's in the eye or it's not in the eye. And if it's not in the eye, it's not going to go in the eye. And if it is in the eye, we'll take care of it.
So Susan just asked, are they sent in with oral prednisone script right away? And yeah, most of the time they are. And what they're trying to avoid here, Susan, is they're trying to avoid maybe that person creating a Bell's palsy. I've never really treated a zoster by using Valtrex and prednisone at the same time. Joe, maybe you can weigh in, but the primary care docs do it all the time because they're worried about the patient developing a Bell's palsy.
Agreed. And interesting, because shingles, zoster can sometimes be confusing. There are things that we also have to ask, what else can it be? You've got some great pictures there, Greg. Not everybody comes in with the vesicular lesions. A lot of times people go on, primary care physicians go on the history. I had a 47-year-old referred over to me with a diagnosis of zoster or shingles, given a script for prednisone as well as Valtrex. And the patient didn't really believe that she had it, nor did I. When she had a pupil defect and an arcuate scotoma, she actually had optic neuritis. The pain of optic neuritis fooled the PCP into thinking it was zoster. And another one we have to always be worried about, very similar presentation, temporal arteritis.
Yep, exactly. Yeah. Susan asked what dose of prednisone. I've seen them on Medrol dose packs, which are 4 milligrams. What is it? 6, 5, 4, 3, 2, 1, 21 pills. But prednisone, if I've seen it prescribed, I think it's, I don't prescribe it, so I don't know the answer, but I think I've seen it like 20 milligrams. I'm not sure if they start off high and come down low, but just a low dose to try and keep that inflammation down. Joe, do you have any answer or better answer than that?
Yeah, virtually all of them are on a Medrol dose pack.
Yeah, seems to be the way they go. So when it comes to these antivirals, one thing you have to be aware of is that they're cleared through the kidneys. And the reason why I bring this up is, if someone has hemodialysis, you're going to want to maybe work with the PCP through their creatinine clearance. The other thing is that on a acute patient that comes in, they're only going to be on it for 7 to 10 days. You don't have to really worry about damaging the kidneys. But there was the herpetic eye disease study number 2 that said, hey, when the patient comes in and they have a second or third episode, you can put them on 400 milligrams twice a day acyclovir. I would just recommend 500 milligrams of Valtrex or valacyclovir for that. But when you go chronic, again, communicate with that PCP, because you want to make sure you're not causing any kidney failure, or any kidney damage that's out there. Not even if the patient's diabetic, especially if they're diabetic, but even in a healthy patient, you want to make sure that if you're going to go chronic, right? The herpetic eye disease study said 400 milligrams twice a day, for a year. Valtrex 500 milligrams once a day. You're probably going to go a year. You just want to make sure you're not causing any harm to those kidneys. So just communicate with, now that's not a phone call to them, that's just a letter to them or some type of communication, and maybe they'll get the kidney function test. When I follow back, I always ask the patient, are you getting those kidneys checked that's out there? So kind of remember that with these chronic oral antivirals. So we'll go through it real quick. They're all generic now, so it makes it really easy. I'm going to tell you, just go write the Valtrex, and I'll show you why here in a second. But, sometimes maybe you can't get it. Maybe it's on back order, it's a supply issue. So you could go with acyclovir, pretty much 800 milligrams 5 times a day is our dose. And the reason why it's 800 milligrams 5 times a day, 4 grams, is that it's poorly absorbed through the GI system. In our gut, it just doesn't absorb. So you're just giving these big, huge horse pills to kind of force it through. The maintenance, again, is 400 milligrams twice a day. That came from the herpetic eye disease study. And again, you're going to see this on every single one of them. Caution with that renal function, because they are cleared through the kidneys. Good news is all the oral antivirals, they're category B. That's kind of the old nomenclature, 2015. That kind of changed, but luckily these were out before that. Remember, there's A, B, C, D, and X. X just sounds bad, so that causes issues. A and B are safe. Most of them are C because they just don't really do, hey, you're pregnant, you mind if we try this drug on you? It's a lot of times if the patient was pregnant, didn't know they were pregnant, and they were taking the medication, is how they find a lot of that stuff out. So these are category B. Now, you're going to find that acyclovir is on label for eye disease, but Valtrex and Famvir or famciclovir, they're not really approved for ocular disease if you look at the label. If you go into like PubMed, you'll find plenty of studies showing that. But if you want to stay on label, and that's why I like to have, this off-label, on-label discussion. You can do off-label discussion. We do off-label prescribing. We do it all the time when we use topical fluoroquinolones as fourth-generation fluoroquinolones for treating that bacterial keratitis. We're going off-label because it's really only approved for bacterial conjunctivitis. But the corneal specialists do it. It's like a Trident commercial. 3 out of 4 do it. So it becomes now the standard of care. Valtrex is approved for genital herpes, but we use it all the time for ocular zoster and ocular, herpes simplex. So you're not going to find it like maybe on the package insert or the PDR, but you can find it in PubMed type of literature that's out there. So it's okay to go off label as long as it, in a sense, is the standard of care. Famvir, I just throw it in there for completeness. Really not used. It's no longer available as branded anymore. They're all generics, but again, it's category B. Again, clear through the kidneys. This is really where you want to live, in a sense. It's a prodrug of acyclovir. That's why it's Val acyclovir, and it comes in 500 and 1,000. I really don't play the game of, zoster is more robust. The simplex is a wimpy virus. These medications are super, super safe. They kind of work in a really unique way. As you know, if you take a medication, it pretty much goes in every cell of your body. It goes into the cell, but the virus produces an enzyme that actually takes this medication and turns it on and kills it. If it goes into a cell that doesn't have the virus, then what it does is it just gets into the cell. The cell has metabolism, and it just basically chews it up in the half-life. So it's really neat the way all of these antivirals work. Again, they go into the cell. The herpes virus happens to be in it. It's producing an enzyme. It cleaves and turns on the medication to kill the virus. So it's really, really cool. I was going with, I don't really play the game where I do 500 here and 1,000 here, so on and so forth. I do, whether it's simplex, zoster, I do 1,000 milligrams in a healthy person, no problems with kidneys, so on and so forth. Not 100-year-old, 87-pound male or female. I would do a normal adult, 1,000 milligrams 3 times a day. Again, the medications are safe. They have some type of immunocompromise going on. That's why they're erupting. And I want to reduce that viral load. And that's just kind of my clinical pearl, I guess, in treating a lot of these over the years. And basically, you're able to do 1 gram 3 times a day for a week. Remember, it's reducing by a full gram, and less medication, less side effects. So that's why I like to go with valacyclovir. And there's another reason coming up here, and it's category B.
Greg, when you talk about that dosing, if you just step back and say, you don't titrate, you just give them a high dose of a very safe medicine. The patient that I got sent in today from their primary care physician, she was 94 years old and probably under 100 pounds, and they put her on 1,000 milligrams 3 times a day. The only difficulty she had was she had to break the pills up and take them a half at a time because they're just large.
Yeah, they are big.
I mean, this was as tiny and frail a person as you can imagine. The PCP gave the full dose.
Yep. Safe medication. She just has to cut it in half to be able to get it down, right?
Mm-hmm.
So here's the herpetic eye disease study. And the number one reason that people dropped out of this study was GI side effects. That was the number one. It really wasn't rash. So the herpetic eye disease study. So my polling question number 5 is, which oral antiviral is lactose-free? Is it acyclovir, Famvir, Valtrex? They all have lactose, or I have no clue. That's why I'm here. Which one of these is lactose-free? Acyclovir, Famvir, Valtrex.
Greg, a question came in. Are these antiviral meds generally more tolerated, GI wise, on an empty stomach or with food?
Yeah, the great question there, Thomas, and we definitely want to give them with some food here. That one to really kind of help that stomach out. And it doesn't have to be a full, big meal. Just, when I talk to my pharmacist, just a few crackers, a little bit of something to kind of get it out of the stomach and moving into and keeping it moving. So if you eat something, it just helps keep things moving. So great question. Some medications you do take on an empty stomach, but not with these ones here. You can take them with food here. Great question. Share the results. All right, let's share these. So yeah, look at that. I have no clue, 55%. They all have lactose, 10%. And the answer is going to be, and that's why it's my number one go-to, is basically Valtrex. If you look right here and you look right here, Famvir and the acyclovir, they both have lactose. And that's one of the reasons they think that there was so much GI upset in the herpetic eye disease studies. But if you look at the non-active ingredients in Valtrex or valacyclovir, there's no lactose, and even the generics right here, all the generics are lactose free. So really simple. You're giving less medication. 1,000 milligrams 3 times a day. Again, as long as it's not that 100 pounds, 100-year-old person. If I'm going maintenance, I'll do 1,000 milligrams 3 times a day and then drop them down to 500. That's out there.
Greg, another good question came in from Timothy. Majority of my patients are not clear and totally asymptomatic after just 1 week of treatment with Valtrex. How may need a prescription for more than 1 week? I think it's a very good question.
Yeah, I think if it's simplex, you're probably going to be pretty much able to beat it up with a gram of Valtrex for a week. The zoster might take another, say, 5 days to a week. But probably if you think it's not clear, it's probably more of maybe an inflammatory reaction, because that's what happens. COVID kind of taught us that. That's what happens is that when you get these bacteria into your body, onto your ocular surface, into the neuron, these bacteria get there and then you kill them. And I always use the analogy, because where I live, I see roadkill all the time. You basically just killed a virus, and it's a foreign protein. That's what COVID was. It was a novel, right? Novel, hate saying that word, novel virus. Our bodies never saw it. Our bodies had that T cell, B cell, make the interferon, make the antibiotic to kill it. But now we have this foreign protein, and what happens is viruses replicate until our body can have a reaction. Then your body kills it. That's not where COVID was the issue. It was whenever we reacted to that foreign protein. And some people had a sniffle to some aches to where they passed away. And that's what happens when you kill a bacteria. That's what happens when you kill this virus, is now you're having maybe an inflammatory reaction. And that's where sometimes these steroids come into play. That's out there. You're just trying to control that immune reaction that from that dead protein, that dead cell membrane that is now sitting there in the body. And we did it. We killed it with the antiviral, the antibiotic. Real quick, is that, is there a difference between acyclovir, Valtrex, and Famvir? I guess if you wanted to kind of use science, Famvir is the safest. Just again, be careful on these patients. I had a patient come in one time. She just came out of Pittsburgh up to where I'm in Altoona, Pennsylvania. She had bilateral cornea transplants from herpes. She had maybe one done 3 times, the other one done twice. Again, she was, 89 years old. She was on 1,000 milligrams of Valtrex, and she kind of had these Charles Bonnet type of, hallucinations going on. And I slowly titrated her down, and these images and these hallucinations went away. So just be careful that they can have some CNS effects in the elderly patient that's out there. All right. Did you ever have a patient that comes in, you can't get Zirgan or Veroptic for 24 to 48 hours. Clinical Pearl is I have my local pharmacy down the street. I'll prescribe wherever the patient wants, but if they can't get it, I have a pharmacy down the street that keeps atropine and Zirgan in stock for me at all times. So I can treat these iritis and I can treat these if I want to use something centrally on this patient like Zirgan. But you can also go oral only. You can add orals and do an amniotic membrane on these patients. So really, can you just go oral for these ocular herpes, these simplex ones? And the answer is yes. There's plenty of literature out there and plenty of studies, and they're actually kind of old studies. I mean, going all the way back to 1986, and they're still kind of surfacing as time goes by. But oral acyclovir alone or oral Valtrex alone, you could treat these patients. I guess maybe a clinical pearl would be if you get something that's central, maybe you want to add some Zirgan. But again, I've had patients, even my pharmacist, that said, hey, look, patient can't afford it. It's $500. And so I've treated these just with orals only. That's out there. All right. Let's shift gears here. That's kind of the first, I guess, if you want to say 50 minutes of some antibiotics and antivirals. Let's jump into maybe some other newer molecules that are out there. Biologics, they're large, they're small, they're nano, super small. I don't know. That's why I'm here. Biologics, you see them on TV all the time. Humira, all those psoriatic arthritis medications that are being advertised. The biologics, are they large? Are they small? Are they super, super tiny? Or you don't know, and that's why you're here. Looks like we're caught up on the questions, Joe.
Yes, we are. And if you want to give a quick clinical pearl based upon something that you just said, when you see these things advertised on TV, anything you see advertised on TV, generally you just can't afford to use it.
Let's see there. You got Carla laughing up there. So that was a good one. She's laughing again. All right. So I'm going to end this poll and share the results here. I think we got the trend going here. Large molecules is the answer. Small, they're definitely not small. They're not nano. And we always like the honest. I should say the other people weren't honest, but the people that are like, I don't know, I don't have a clue. That's why I'm here. And that was 33%. So let's jump into here and small molecule versus large molecules. When we talk about small molecule drugs, it's kind of like our aspirins and, maybe our timolols and our, Veroptic and acyclovir that we just talked about. Biologics, they're a total different animal. It's basically genetic engineering. So small molecules will be like aspirin. When we talk atoms, we're talking 20 to 100 atoms here. When we're talking hormones, maybe like an insulin, we're talking 200 to 3,000 atoms. But biologics, they're huge. They're huge molecules. That's why, one, they're expensive. They have to be shipped a certain way. Sometimes they can only be in glass, kind of like oxyrvate that we're going to be talking about. So biologics, again, here, just to kind of show you, aspirin is this size. A lot of the biologics go after the immune system. They're kind of, they're basically IgG or some type of immunoglobulin that's been kind of created to kind of upregulate or downregulate kind of that immune system. And we'll keep talking about that a little bit more. So again, small molecule drugs like aspirin would be like a bike, and hormones, human growth hormone at 3,000 would maybe be the complexity of a car. But when you get to biologics, they're super complex, and they would be like the complexity of a jet airplane. And that's why, again, when you see them advertised on TV, and I know Joe says that truthfully and jokingly, it's, you can't really maybe afford them that's out there if they're on TV because, they're new. But biologics in general are just expensive. And the reason being, like for oxyrvate, it's a human growth hormone. It's a nerve growth hormone. And someone figured out the DNA sequence of that. and they plugged it into, I think, E. coli. We'll get to there. And then it kind of replicates and spits it out. And then the scientists, some way, somehow figure out how to twist it up and make it look like a nerve growth factor that's out there. The same thing with Tepezza. They find out the DNA structure, they plug it into a yeast, a bacteria. It's kind of like a surrogate mother is the way I look at it. And it spins it out and creates that protein through the replication. And then it gets turned into the medication. So these things are large molecules. And what I wanted to talk about tonight is, I have a whole lecture on biologics, but we could, just take a little kind of skim the surface here. Biologics, biosimilars, biobetters. And biologics are the ones like Humira that we've seen. A biosimilar would be, in our mind, would be like a generic, but there really can't be a generic biologic. If I figure out the DNA sequence of human nerve growth factor, I can have that DNA sequence. I can give it to Joe. I can give it to Vanessa. I can give it to whoever. They're just going to use maybe different bacteria, yeast, put it in. It's still going to spit out through that kind of DNA processing, the sequence, and then you got to figure out how to twist it up, and maybe it's going to be some inactive ingredients. But that's why, if like for thyroid eye disease, teprotumumab is going to be teprotumumab because there's no generic to it. That would be a biosimilar. It looks like the reference. So all the money is spent in the reference or innovator, and then there's a biosimilar. Then there's biobetters or biosuperiors, where they actually take that, change it a little bit, and it makes it work better. That's out there. So we have in an eye care our first Lucentis, which is, I always butcher these up, ranibizumab. And the MAB stands for monoclonal antibody. And so you have Lucentis here. And when they came out with the generic, notice how it's ranibizumab, right? But what are these letters here? These letters mean absolutely nothing. It looks like someone leaned on the keyboard. And the reason being now, because there are registries, how would you know if it was this one or this one? Because it's the same exact molecule. They figured out the DNA sequence, whatever it is, put it into it, twisted it up, and it ends up being the molecule. Well, that's why they tagged this on here, to see maybe if one will be better than the other. So these letters mean absolutely nothing. NUNA, this here is the reference molecule. This is the reference molecule. This would be a biosimilar. And we have the first one in ophthalmology, in a sense, with this. Now, a biobetter, this is basically a biologic and a biosimilar. You can kind of say they are intentionally similar in design, but a biobetter is that's out there, and there's really nothing in eye care. I talked to Tracy the other day, and she basically said, that this is for the first biobetter that came out. This monoclonal antibody by Genentech became a biobetter of this other, I always butcher the names up, so I'm not going to say them here, but of this molecule, this monoclonal antibody, they improved it and it became a biobetter. We really don't have any in eye care, but you might hear that name. All right. So with that being said, let's do polling question number 7. Which biological drug has been around the longest? Is it oxyrvate? Is it Tepezza? Is it Actemra or tocilizumab? Or has it been Avastin?
And we're good on the questions. Nothing's going on right now, Greg. You're all covered.
Perfect. It looks like everyone's nailing this one here. Which biologic has been around the longest in eye care? So I'm just going to end it and we're going to share it. And that is correct. Avastin is a biologic. It's there to inhibit the VEGF, and it's been around the longest and used in eye care. So to treat choroidal neovascularization, it's been used in retinopathy of prematurity, diabetic retinopathy, basically these anti-VEGF molecules have been around as the earliest that's out there. But since then, other biologics have come along. So I think the first one that came out, which is not really a biologic, which is an amptomer, was Macugen. But then we have Avastin, Lucentis, and Eylea, which, as you can see here, full-length monoclonal antibodies. And these are protein biologics down here. Then we had Beovu come out, and that was by Novartis, and that was, it was October 2019, and it quickly disappeared. And the reason being is this right here, is that when it was injected into the eye, certain amount of patients had an antibody to that, and it was creating vascular occlusions. So in this study, they showed of an N of 1,000 patients, or almost 1,100 patients, ocular inflammation occurred in 4%, almost 5%, 50 people. And then they had the ocular inflammation and retinal vasculitis, the ocular inflammation and retinal vasculitis and artery vascular occlusion in 2%, 23. So then the thought process, well, because remember the Beovu, the whole idea was that it could last, up to 3 months. The patient, supposedly, if you wanted to use it, the thought process was, we'll check the patient for the antibody. Well, the drawback is that's fine, but when you inject it, the patient can develop the allergic reaction, if you want to call that, or the antibody for it. So basically, that's why Beovu kind of fell off to the side, because of these ocular inflammations that were out there. We already talked about this as a biosimilar. I have the slides reversed there. But here, what I have is showing again that that medication that came out. Now, advertised on TV is now we have this Vabysmo that has come out. And you could see just by looking at the name here, the structure, it's a monoclonal antibody. And really, its claim to fame is that not only is it a VEGF, it's a two-path driven, where now it's going after the angiopoietin 2 inhibitor. And with that being said, it's from Genentech, and I got this right from their website, so I'm going to give them credit for where this picture came from. It could be used anywhere when it's injected. You can get the effect to be 1 to 4 months. So again, you see it on TV. I've seen it advertised. I really haven't seen my retinologist using it yet. But again, it's another monoclonal antibody. And this SVOA means absolutely nothing other than it's tied to Genentech. If another one comes out, it will have 4 other letters at the end, and that will just be 4 different letters to help it be the other company when it becomes that biosimilar. This would be the reference molecule, and if something comes out, then it would be the biosimilar.
And there's a question about the vasculitis occurring in Syfovre. Is a similar reason you think to Beovu? Well, I've heard about this as well for the geographic atrophy medicine.
Yeah, I'd have to take a little deeper dive. I just started working a little bit closer with Apellis to take a deeper dive, working with the medical science liaison. We're going to talk about it here. It's good lead in here. It's a different type of, it's an amptomer. It's not a biologic, but you're going to see that it does have the chance to create a choroidal neovascular membrane. And when I lecture with Dr. Offerdahl, when she and I've been geeking out for about 15 years, we've been lecturing together. Anytime you mess around with the immune system, you're tinkering with the immune system, is what we're going to show you here coming up in a few slides, is that you can then get some type of a reaction. So I don't think, off the top of my head here, Natalie and Joe, that is it the same that the patient has an antibiotic, has the antibody to Syfovre, I think that it's probably you're just monkeying around with the immune system here, the complement system, and then you create a vasculitis. So I don't think it's maybe that antibiotic relationship that's out there, but that's just to me kind of knowing kind of a little bit how these things work. So thank you for bringing that up, Natalie, because that's a nice little segue here into geographic atrophy. And geographic atrophy, I found this the other day. This was a patient that in 2019, this is a fundus autofluorescent photo, and black is not good, and white means that there's activity. So you can still see the activity going on here. You can see back here, they had some geographic atrophy. This might be the place where you would use Syfovre. So Syfovre is SY Science Fovea Retina. When I was at AOA, I got to meet with the Apellis people. I'm like, how'd you come up with that name? So the SY is Science Fovea, and then Retina is how the name came up. But this was 2019. This is just recent here, June 26, 2023. You could see here that they advanced. Now, this might be the patient that we could say, hey, do you want to consider Syfovre? But now they're getting an injection once a month, every 3 months. They would have had to keep that up all that time. My retinologist is still I talk to them quite a bit. He's still trying to figure out where it's going to be plugged in. Joe, are you using it in your practice at all?
There is a little bit being used.
So that's going to be the challenge. And I think it's kind of funny because this is more of a preventative medicine being used in an allopathic world that's out there. And I think it's going to be neat to kind of see how this unfolds. So this is just me showing just geographic atrophy and how fundus autofluorescence is important. And you can see there's some activity going on here. Black is kind of some damaged area, damage here. You can see the activity would be right here. So, we're going to get a little love back to our fundus photography here. This is with a lot of my lectures. I always kind of tout this. If you kind of want to learn about the immune system in a nice way, and you want to watch some YouTubes, go to Ninja Nerd, type in the immune. He's amazing. He teaches like these medical students to help go past their boards. He has a little bit of this drawn, and all he does is just starts drawing. This is the adaptive immune system. This is the innate immune system on this side. You get something in your body and immediately it reacts because you got macrophages, so on and so forth. And then it comes over here and gets into your T cells and B cells, and you got all your interleukins here, creating then the plasma cells and the interferons. But right here, if you look, he talks about that other system, the classic, the alternative, and the lectin system here. And this is your complement system, right? Your complement, it creates that membrane attack complex. So you got a different, that's usually like, I think of it as a stick of dynamite. It plugs into the bacteria. It's like a straw. It fills up with water and it explodes. That's your complement system. That's what these medications, Syfovre, are going for. That's going after the complement system that's here. So if you look, this is where you hear me when I talk about macular degeneration. Macular degeneration is an outer retina disease. That's why I'm not a big, huge fan if we're going to do some type of antioxidant. There's really no carotenoids in the RPE. That's your resveratrols and all your other flavonoids and polyphenols that are out here in the outer retina. The carotenoids, they're way in the inner retina, okay? And they're just in the fovea. This disease, when you have these genetic mutations, the C3, the C5, the complement factor H, the genetic mutations are down here in the RPE. This is where the immune reaction is happening. Right? So this is your genetic SNPs. This is the disease. And then you get the immune reaction. And the way I kind of think of it is a hard drusen can turn into a soft drusen. How does a hard drusen turn into a soft drusen? It's that immunological reaction of the complement factor system attacking that drusen, right? So that's where the Syfovres and then the Iveric is going to be coming out with one. So that's why, you'll see me talk about this. This isn't happening to all my patients, but the disease is out here. And here's a patient that I went aggressive, full antioxidant, everything, A through Z, polyphenols, resveratrol, so on and so forth. And you can see you can get reversal that's out there. We're not going to turn this into a nutritional lecture, but my point is the disease is in the outer retina at the Brooks membrane, RPE. It's not up here in the inner retina that's out there. And that was taught to us, from the people that come up with the dark adaptation. Here's Brooks membrane, here's the RPE, here's the drusen starting to form. You just can't see it until it gets large enough, and then we call it a drusen. So we can intervene early in this disease, and that's where we're going through with these complement factors, right? That's what Syfovre came out with here. And this was Apellis, and it's indicated for the treatment of geographic atrophy, and it's the first approved. It's inhibiting this C3 activation. This is from their website. They have a nice little video. I kind of paused it, screenshot it, whatever, clipped it, and put it in. So I'm going to give them reference here. But you can see, I just showed you back here on here. Here's your lectin, classic, and alternative complement. And here it's showing up here. And the first thing that happens in that pathway, one of the first things that happen, if you look, you're going to see C3 in here. And that's what this is. It's going to try and inhibit this C3 to prevent this immune reaction, which is inflammation, phagocytosis, and cell disruption. So it's trying to inhibit. That's that mechanism of action, right? So this is not a mechanism of delivery. You have to still inject it. But this is a peptide, a synthetic peptide that is trying to slow down this overreactive type of immune system, right? They have the genetic predisposition. They've created inflammation. Now you've turned on the immune system. Now what we're trying to do with this inhibitor is to try and stop that from happening. And then this is Iveric. They probably will have a medication approved this year that's out there. It's already gone through research, preclinical, 1, 2, and 3. It's under FDA review. I think they might even have a PDUFA date, which is the date that they have to be a ruling by. Things can come out earlier. So the mechanism of action is this one is inhibiting down here at the C5, right? So I'm just using the Syfovre to kind of show you that maybe it'll be a little bit different in the side effect profile because it's a little further down the pathway. We're not hitting it up as high. So there's aptamers and there's antibodies. There is a difference, right? We just talked about the biological process. These are not biologics, the Syfovre and the Iveric molecule. And, there's some thoughts that because they're not biologic, they're more stable. They're easier to synthesize. I just told you have to get through this whole DNA and inject it and do all this stuff and spin it up. And the smaller size makes it a little bit easier. And that low to no immunogenicity that Natalie was talking about with that vasculitis. So I don't think it's kind of the same type of reaction because this is more of an antibody to antibody reaction that was out there. So we'll stay tuned to see what some more side effects are. And that's the way it is. When they do these studies and they have 1,000 people, when you inject it into 50,000 people, that's when you start seeing a lot of the more side effects. All right. Whew. So what's our diagnosis here? We have this stuff building up on these eyelashes. We got some redness, and our diagnosis would be Demodex. And we have out there as a non-allopathic treatment would be Claridex, tea tree oil, right? That has been effective, but maybe not as effective as we want from time to time. So there's something new coming along. And, you'll see me, there's a video here. Let's see if we played a video. And if you look here, Joe knows one of my favorite things to talk about with Demodex is when you look here at this stuff building up on the eyelashes and you see the redness and inflammation. I'm going to pause it right here. You see this here, and then you got the redness and injection. You can see what's happening here. This is nothing more than Demodex poop. It literally is a byproduct of this Demodex living there. And we know that, poop can be irritating. A baby goes to the bathroom in its diaper, you don't notice it, and the baby ends up with a red bottom. Well, look here, you have poop from this and your body's reacting to it. So that's what's happening here with these patients. That's all this is. You get an overbuildup of this mite in the body or on the eyelashes, and you're starting to get this type of reaction. This is just another video of this kind of classic buildup right here at the base of the lashes. And the patient, you can see the redness and the injection coming down from this immunoreaction that's occurring. So, Demodex blepharitis, we have tea tree oil, and there's this molecule called TPO3 that was under investigation. And there's different types of Demodex that's out there, this follicularum and brevis that's out there. And we could see here that there's a mechanical issue. There's a bacterial side where the Demodex can contribute to allowing the bacteria to then take over, and there's chemical reaction. So there's a lot of things. This is a multifactorial mechanism of this disease. And we could see we can get disorders of the eyelashes and meibomian gland dysfunction and the red and inflamed lid margins, and it can lead to corneal keratitis and conjunctival inflammation. So, 80% of the patients report a negative impact in their life. You can see itchy eyes, dry eyes. So this is something that we want to treat. We had tea tree oil Cleardex, but it'd be nice to have something a little bit stronger. And that was this TPO3 that was being studied. And the target is really cool at how this works. The arachnid has this GABA-gated chloride channel, and our body doesn't have this. So that's why this is a super safe medication, because really only the Demodex has this. So you're really, what you're doing is you're kind of paralyzing it. So I was at a KOL meeting and I said, well, first of all, this is poop building up on the lid margin. You're creating that kind of allergic reaction, so on and so forth, the inflammation, so on and so forth. So now what you're doing is you're using this medication in a sense to paralyze it, so it can't eat, it can't move, it can't have sex and replicate, and it just basically gives up. And one of the scientists said, well, I guess that's a good way of thinking about it, because that's what it's doing by inhibiting it. But this medication only targets what's in the Demodex, and it's not going to affect us as humans because we don't have this GABA-gated chloride channel that this medication is going after. Not currently FDA approved. Well, we like to deliver up-to-date information. This was just approved today. So I got a little pop-up on my phone. It's preserved with sorbate. And what I think this medication is going to be a success, because it's not chronic. It's twice a day for 6 weeks. And I've seen a lot of the studies. As I said, I sat in a KOL meeting. I think it was at the Academy last year in San Diego. A lot of before and after pictures. I think this is going to be a nice success because it targets the bug. It's safe for us. We don't have this GABA-gated chloride channel. It's not a chronic medication that we're putting the patient on forever. It's twice a day for 6 weeks. So I'm really excited today that it was approved, and it looks like it's going to be called, I don't know, Xdemvy. It was just approved today. This was on review. And you can see right there is the name of the medication. TPO3 was the study name, and now we have Xdemvy, I guess. I guess the Tarsus people will give us the non-Caldwell butchered name. So speaking of things that are recently approved, Mibo by B&L was approved. This was out in Europe for years. So I was just Joe and I were lecturing in Heidelberg. I was in Poland lecturing, and Theolos Duo This was your Ivisia that has been out. That was in Europe for years. And this Evo Tears, and if you look right on it here, it says the perfluorohexooctane is what this is. And the good news is, whenever I was there and they talked about it in Europe, they worked very, very well. So I'm excited for this MIBO because it's really targeting the evaporative disease. So it's going to be really neat. Spoke with the B&L people. They're really in the process of launching this. It's really, everything else goes after inflammation. Everything goes after the aqueous deficient side. MIBO here is going after the evaporation side. So it's going to help with that meibomian gland and the evaporative side of this disease. So it's going to be neat, but that's going to be a prescription that's out there. So that was recently approved. So Vuity here, I kind of opened up with it a little bit earlier. It's really hasn't had the best launch, so on and so forth. But what I wanted to talk about with it is it's really not a mechanism of action type of wow, it's pilocarpine. When it came out, it was more of a mechanism of delivery change. I was in the day when I was at PCO, and I told you I was there 91 to 95. We didn't have the Zalotans, we didn't have the Cosops and the Comigans and so on and so forth. We were treating things with Timolol and Pilo and Propene and things like that. And the pH of this was really, really low. That's why it burned when you put it in, the pH of Pilo. So what, AbbVie and Allergan did is they basically, that's why they call it the pH or the FAST technology, using the pH there, is they changed the pH. It was in the bottle, again, still that kind of 4, but as soon as it hit the eye, it got to a 6.5 very quickly. So it really didn't burn for a long period of time. And then what that did in that mechanism of delivery and changing the pH, it allowed the bioavailability and the tolerability to be increased. So, I don't think a lot of us were blown away by the mechanism of action. What Vuity is more of a mechanism of delivery that's out there. And you could see here by changing that and comparing it to pilocarpine that it still allowed it to work quicker and allowed it to work better. That's out there. So the reason why I bring that up is because this market is not going away quite yet. Whenever I was at the AOA, I met with some of the companies out there and some MSLs, and you could see here that, they're still looking at, we talk about dry eye all the time. There's 16 million diagnosed, and you have, total patients of 1.64 million. Presbyopia is a much bigger market. Right. So they're still going to keep looking at that. They're still going to try and find something out there that's working. So I got a lot of these slides from Orasis and working with their medical science liaisons that are part of the company. Again, Vuity is approved. And again, it's 1.25%. Now, what have they've done here with their molecule is it's a much lower percent. It's still pilocarpine, right? Again, it goes back to that mechanism of delivery, not the mechanism of action that's out there. We have Inova, we have Visis, we got these Lens, we've got all kinds of companies out here working in this space that's coming out, but Orasis, probably the CSF1, a much lower dose of pilocarpine, is probably going to be approved this year. So, what makes it different? Again, it's not really the mechanism of action. It's more or less the mechanism of delivery, the low concentration of Pilo, the near neutral pH, the preservative-free part of it. So again, you're not going to be blown away. Pilocarpine's pilocarpine, but where when I geek out with Tracy, it's the mechanism of delivery, right? Vodka is vodka, but some people like it in cranberry juice. Some people like it in orange juice. Some people like it in a Moscow Mule. It's still all vodka, but it's kind of the mechanism of delivery that's out there. So I just bring this up because there's going to probably be at the end of the year another type of presbyopia drop. I don't think this space is going away because of the what I just showed you, the 120 million people that are presbyopic, it's just a space that that there's opportunity in there. And then there's their PDUFA date right here. This is an acronym for something. Basically, you hear PDUFA date, they have to rule on it by October 22nd. I think August 24th or something around that was the Tarsus date, and they came out a month early. So it all depends, how, I guess, how they're caught up. But again, the vehicle, it's the mechanism of delivery here. So just stay tuned. That's out there. And it's, again, very well studied. The FDA tells them to do it at one eye. They tested it with both eyes, and they got a lot of improvement, so on and so forth. It's out there. All right. Let's talk real quick about two more molecules here. Neurotrophic keratitis. We're going to switch back gears, go into a biologic. And what I love about this, and I should have put the picture in here, when I was at AOA, I got to meet with Sergio Dompe. I was the sales team put together. Paul Karpecki was there, Selena McGee, Stephanie Wu, myself, a few other people. They flew in, they flew their scientists in, and we got to hang out. And one of the things that I brought up to them was, listen, most biologics are immunosuppressant, monkeying with the immune system. This molecule is a biologic and maybe can be confused, and maybe that scares us as optometrists to use it, but it's really nothing with the immune system. It is actually nerve growth factor that it's going out. Now, one of the things, and I use a lot of this now because, man, have I gotten some really good success, which of these two eyes is going to be more symptomatic? Is it this patient here with all this staining, or is it this patient? And wait, it's actually the patient that is more symptomatic is this eye. How is this eye comfortable? As dry eye advances, and I call this like stage 7 dry eye, you have that patient that comes in, they're watering, they got foreign body sensation. And we've all seen it where we put stain in the eye and it looks like a Montana starry night. And the patient's like, yeah, man, my eyes feel great. They used to burn and hurt. And we've seen people with little abrasions. That's not good. They're neurotrophic. That is not a good sign. And the way you check for this is to do cornea sensitivity testing. Cornea sensitivity testing is now cool. Here, watch this. Boom, blink, boom, blink. Watch what happens when we go to the other eye here. Now, this is a patient with herpes simplex. You can see the dendrite starting to bust out here. I was trying to test to see, and I could just drag this right across. Now, this isn't from dry eye. This is neurotrophic because, remember, it's a neuronal virus that's out there. But that's how you check for cornea sensitivity. Here's another one. This is someone had cataract surgery, had dry eye for years. And you could see here, whenever I test them, I just take a cotton tip applicator, pull the top off. There's a little strand there, and I touch them. And notice how I'm touching them here, and they're hardly even blinking, right? That is not good. That patient is neurotrophic. And you want to test the different parts of the eye, pretty much superior nasal temporal, inferior nasal temporal, and then central. Those are kind of the 5 zones where you want to test. And then it's not really hard, it's absent, it's reduced, or it's normal. And then you grade the staining, and then you can apply for oxyrvate. I can tell you, I have case after case where these patients have come in and I'm testing them here and they don't feel it. They're neurotrophic and they're not able to heal. You're breaking down that feedback loop. When you have the feeling, the brain then tells the body to send things down the hill. When your body says, hey, look, you're not going to help me, you're not going to fix me, it then just down regulates that nerve, and that's not good. Now you're not getting the feedback system. You can see there's all kind of staining here on this patient. Even with the white light, you can see it, and they can hardly even feel it. I think this patient here, I just bumped their eyelid and they start blinking. But you get the point. You need to test these patients. These patients here are neurotrophic. This patient couldn't even feel this in their eye. That's not good. And that's where oxyrvate or Centergermin comes into play. But this is not an autoimmune tinkering with the immune system. This is human nerve growth factor, or it's nerve growth factor that looks like human nerve growth factor. And that was before, and this is after. This is a great medication. I love it. There's a process to get it that you have to go through. But again, it doesn't monkey with the immune system. So you grade it very simply, normal, reduced, or absent, right? So you touch this, it's either reduced or absent. And then you can grade it on the staining, grade 1, grade 2, grade 3. Grade 3 is you're starting to get a little bit of stromal atrophy, right? So a lot of the times what we're looking at is stage 1 is more like kind of an SPK. Stage 2, it starts to become more coalesced. But you can see here, stage 3, you're kind of getting that breakdown of the stroma. So again, just grading these are stage 2 because you can see the coalescence here. This is huge stage 2. It's all over the cornea, but I don't see that stromal atrophy to cause it to be a stage 3 or severe. Again, I see these all the time. They get referred in. They tried everything. They've tried tears and plugs and Restasis and Sequa and Xiidra and da-da-da-da-da. And they're just stage 7 dry eye. You touch these corneas, they don't feel it. They're not getting that feedback loop. And you could use something. Look at this cornea here to this here. Tell me this patient is not excited. 20/60-ish vision down to 20/20, 20/25 vision. Medication I really, really like. It was approved in 2018. Dompe Pharmacia, it's an Italian company. It's a really good biologic medication, but it doesn't tinker with the immune system. A lot of times what I do is I play these videos, but I didn't hook up the sound. But basically, you could see this lady, she goes through and she improves. I just kind of watched her over that 8-week period. But what I like to, when I play the video, it's really confusing when they talk. They all do it like, my eye feels better, but yet it hurts. Remember, pain is very complicated. There's all kinds of fibers, right? You hit your finger, acute pain, it throbs. You get all these sensations. So as they're getting their feeling back in their eye, they're like, oh my gosh, my eye feels better, but yet it hurts. So it's kind of a neat way of, now that I've treated about 30 or 40 patients with this, they all kind of give that kind of like, I feel better, but yet it hurts. Like, which one is it? Tell me what it is, because you're now bringing back feeling to the eye. So I'm just going to kind of skip through here. So they did trials, and basically they were able to heal 72%. And then of those 72, 80% were still healed a year later. I've had to use on my 30 patients, I've had to use 3 or 4 times twice. And there's one patient I did a 3-time dosing, but we got them healed. Most of the time, it's just 1 time. Again, it's not monkeying with the immune system, so it's very well tolerated. It's a nerve growth factor. It's not monkeying with the immune system. And in the next 5 minutes here, I just want to talk about a medication that's been really positive for the thyroid eye disease patient. Really, what you have to kind of learn is the clinical activity score. We were all taught the no specs classification. I don't really keep this pinned up in my room. I got 2 computer screens in my room. I Google clinical activity score. And basically the biggest change that came out from this in Horizon is now they have approved it, and the FDA is now working with the insurance companies. If they really have any stage, early or late, you can send them for Tepezza. And really before, how it was is you looked at the first 7 here. These are all worth 1 point. Painful eye behind the globe, pain on attempted gaze, redness on eyelids. These are all worth. This wasn't like 4 points for redness of the conjunctiva. Before, if they had 3 or 4, they would most likely get approved, have to go through the whole process. 8, 9, and 10 were for follow-ups. Now what has changed is they're able to now, if they just have chemosis or pain, you can send them to see if they can get approved and get the Tepezza or the teprotumumab. This was a patient here. Let's see who's off. Okay, we got it. So we have a patient here that came in. I always tell the story of, Sarah diagnosed this patient. This was a little bit of a tough diagnosis, was missed by a couple of eye clinics in town because it's a he and older, but he has thyroid eye disease. You could see he even has he's got double vision. He's got limited gaze. This is a pretty advanced thyroid eye disease. This was before teprotumumab was out. So I had to work with a immunologist, or work with the rheumatologist, and we got him on some IV steroids and oral steroids, and we were able to calm him down. But I just want to show you what thyroid eye disease looks like. And if we put this gentleman on, we're not going to do polling question number 8. The answer would be Tepezza here. What is indicated? If we would put him through the clinical activity score, if we go back to here, the clinical activity score, he would be painful behind the globe, pain on attempted gaze, redness. He's a 7 for 7. He would have been perfect for Tepezza. And if he's still active, he actually moved to the Pittsburgh area to be with his family. If he's still active today, the new breakthrough would be he could still get Tepezza being this far out. So Tepezza is what we use for thyroid eye disease, or teprotumumab. Look, it's a monoclonal antibody. It's a biologic. The big boy biologics, Remicade and Humira, that's why you see them on TV, they're immunosuppressive. They're really shutting that immune system. That's why 5 seconds of what it does, 25 seconds of all the bad side effects. This is more immunomodulatory. They're getting better with these. And remember, thyroid eye disease is an orbital disease, and it's going in and targeting the inflammation through it's inhibiting the insulin growth factor 1 receptor. So here's the orbital disease. Here's your thyroid stimulating antibody, but here's the insulin growth factor. It's this beta arrestin that connects it, so that when both of these are activated, it creates the inflammation. They didn't really go after this side to downregulate it with Tepezza. They went on this side, and because it's connected to this beta arrestin, it downregulates the inflammation, but you're tinkering with the immune system. So that's what teprotumumab does by being one of the new medications in eye care. It's very well studied. It's a very safe medication. What you're going to see is hyperglycemia, because again, it's working on this insulin growth factor 1 as a down regulator. So it can cause a high sugar spike in the patients, or hypoglycemia, but it's very well tolerated. There it is, hyperglycemia. You can get some infusion reactions. They're very large, right? That's why like Oxervate comes in a big little vials. You draw it up and drop it on the eye. A lot of these biologics, they're infused because they're large, right? You can't shake them. They unwind real easy. They're really, really delicate. So biologics are large, delicate, usually infused type of medications. So if you're interested, you can just go to their website, find the local rep. I have 2 infusion centers near me, and that's all I do. I can't prescribe it. I send them over using the clinical activity score, and we get the patients treated. The reason why I bring it up, because back in the day, they used these big boys here to treat the patients, and now we have something that's a little bit less side effect. So that's why it's worth discussing with the patient. So with that being said, that puts us, look at that, 9:50, right where we want to be. My last polling question will be, I gained some knowledge in ocular pharmacology from this presentation. Yes, no, and why I put this in here, it allows me to clean up any questions. Joe, any questions?
I don't think so, Gray. Nope, no questions, just one final comment, that's all. About the new lotilaner drug being approved.
Yep.
Now, there are some more Tepezza studies and more thyroid eye disease studies going on. I had a patient when I diagnosed with thyroid eye disease last week. CAT scan patient had restrictive myopathy. And it is actually kind of important to get those imaging studies, because one thing that was identified was there's some mild compression of the optic nerve. So a lot of these patients on imaging have compressive optic neuropathy. And, I was talking to the patient and told her what we needed to do. And she said, well, what if I just do nothing? So that's not an option because you can actually lose your vision if this expands further. So, the CT scan, very helpful in making the diagnosis with restricted myopathy. You find out a lot of these patients actually have compression of the optic nerve. And I think we're going to get into a thyroid eye disease study locally.
Oh, that'd be
So a
great.
lot more going on with thyroid eye disease.
Yeah. Well, Joe, thank you for those comments. Any other comments that you have?
Nope, but I think this was a great wide-ranging talk on a lot of challenging topics. You played it like a symphony, Greg.
Well, thank you. Very kind. And I see people they gained some knowledge. That makes me feel good to see that up there. So thanks everyone for attending. This will wrap up ocular pharmacology, utilizing old and new medications in eye care.